Welcome back, students, to Decode Healthcare. I'm your lead instructor, Harshal. So in our last lesson, part 134, we mapped out payer denials and audit defense mechanics. You know, things like RAC, MAC, and commercial DRG downgrades. Well, today we're executing the defender's playbook in this explainer. We're zooming in on clinical validation defense strategies for high acuity codes. I'm talking about A41.9 for sepsis, G93.40 for encephalopathy, and E43 for severe malnutrition. It's going to be a deep dive.
But hey, before we jump in, a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
All right, here's our roadmap for today. We'll cover 1. The stakes of validation denials. 2. The battlefield, which is our big 3 targets. 3. The arsenal of compliant queries. And 4. Our summary and next steps. Let's get into it.
Number 1. The stakes. Let's talk about validation denials and the real financial impact they carry. Think about the MSDRG architecture. The system basically creates 3 distinct tiers for almost every MSDRG. You've got with MCC, that's a major complication or comorbidity, then with CC, and without CC or MCC. Your hospital's final payment, it's calculated by multiplying the base rate by the DRG's relative weight. So, if an auditor downgrades an MCC, like sepsis, down to a simple infection, your MSDRG tier literally plummets. It's a staggering reality that a single missing word in a chart can trigger a 5-figure clawback. That's massive revenue loss for the complex care you've already provided.
Now, the absolutely crucial point here is that clinical validation isn't just about finding a code. It's about proving the medical necessity and severity of that condition through objective evidence. Because here's the thing. Commercial and government auditors will challenge a physician's diagnosis, even if it's explicitly written in the record, if they feel it lacks clinical criteria. They enforce these really narrow diagnostic definitions to deny high acuity codes. So your documentation has to accurately reflect the patient's true severity of illness to prevent those downgrades.
Okay, moving on to number 2, the battlefield. We're going to break down the big 3 high-volume audit targets. Consider the stark contrast between explicit documentation, words like severe sepsis or septic shock, versus implicit hints hidden in the chart like pneumonia with acute kidney injury and elevated lactic acid. An auditor or coder simply cannot assume those implicit indicators mean sepsis without a query. It's a massive compliance trap, guys. You absolutely must have explicit documentation to assign those higher-weighted codes from the A40 to A41 categories.
So, to defend sepsis against auditor downgrades when they try to drop it to transient bacteremia, localized pneumonia, or an uncomplicated UTI, you must actively document specific systemic indicators and organ dysfunctions. We are talking about the Sepsis 3 definition here, which defines it as a life-threatening organ dysfunction with a SOFA score of 2 or higher. You need concrete metrics: tachypnea, tachycardia, elevated lactic acid specifically greater than 2 millimoles per liter, hypotension, thrombocytopenia, and explicit organ failures like acute kidney injury or acute respiratory failure. Plus, you have to show the work, meaning aggressive fluid resuscitation logs and blood culture management.
Next up, encephalopathy, which is essentially any disorder or malfunction of the brain. Our defense here relies entirely on differentiating a true acute metabolic or toxic brain dysfunction from a patient's baseline dementia, sundowning, or simple altered mental status. To validate this MCC, your documentation has to pinpoint the specific trigger. Was it hyponatremia, a UTI? You need to document elevated ammonia levels or acidosis, log objective neuroassessments, and cite diagnostic workups like EEGs or neuroimaging. Prove that acute change from their baseline.
For our third major target, malnutrition, vague documentation absolutely won't survive an audit. No way. You have to utilize dedicated nutrition consults to explicitly validate severe malnutrition against recognized clinical criteria, like the Joint Aspen and Academy of Nutrition and Dietetics guidelines. That's what secures your MCC tier. To defend against payer downgrades to mild malnutrition or normal nutritional status, you've got to document key indicators. We're looking for severe weight loss percentages over time, energy intake reduction of less than 50% for 5 or more days, muscle wasting, subcutaneous fat loss, and fluid accumulation or edema.
All right, we know our targets. Let's transition into part 3, the arsenal. How do we use compliant queries and appeals to lock down these high acuity codes before billing?
Official governing bodies, like AHIMA and ACDIS, mandate exactly how we construct our queries. The golden rule is simple but incredibly strict. You cannot lead a physician to a diagnosis. You must provide clinical evidence straight from the record and offer multiple clinically reasonable choices, including an option that results in no change to the code. This is what protects the hospital from being accused of unethical upcoding.
Let's think about a real-world compliance danger. A bad leading query might say something like, "Can we code this low hemoglobin as acute blood loss anemia?" That suggests the diagnosis directly and introduces bias. Definitely not allowed. But a compliant, non-leading query relies entirely on objective, open-ended clinical indicators. It sounds more like, "HGB is 6.2 following surgery. Can you clarify if anemia is acute, chronic, or due to another cause?" It's totally evidence-based, and most importantly, it maintains auditability.
To build an unbeatable appeal dossier and pre-bill committee, your team has to systematically flow through 6 exact steps to synthesize physician notes, lab trends, and coding guidelines. It starts with the CDI review to spot incomplete documentation. Then, you draft a compliant query. Next is query routing, often using EHR integrations to send it right to the physician's inbox. After that, you secure the provider's response, the coder updates the final MSDRG, and finally, everything is logged for audit and reporting. When you're building appeal letters, this synthesized data is your ammo. You must forcefully cite authoritative consensus definitions from groups like SCCM, ASPEN, or the American Academy of Neurology, right alongside official ICD-10 guidelines. That prohibits auditors from substituting their own clinical judgment for your provider's actual documentation.
Which brings us to part 4, summary and next steps. Let's debrief on everything we've armed ourselves with today.
Here are your major takeaways. Ethical optimization requires you to anchor every single CC and MCC to concrete clinical indicators, like lactate or ammonia levels. You protect your MSDRG weights by fighting vague documentation. Always use strictly compliant, evidence-based, non-leading queries to clarify those gaps. And finally, integrate CDI, coding, and physician advisors to establish rigorous pre-bill review workflows. That's how you block payer clawbacks before they even happen.
I want to leave you with a provocative thought to evaluate your own facility's readiness. Are your clinical documentation practices truly robust enough to survive a targeted recovery audit contractor or RAC review? Think about your defense strategies right now before we move on to part 136, where we'll tackle quality programs, hospital-acquired conditions, and PSI 90 penalties.
Thank you so much for joining me for this deep dive, students. And remember, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you in the next explainer.